Hello, ladies and gentlemen. Thank you for joining me. I'm Dr. Silva, and today I'm going to talk to you about minimizing sexual dysfunction, and specifically anorgasmia. Today I'm going to talk to you about how to minimize sexual dysfunction due to serotonergic medications, antidepressants and anti-anxiety medications that work by increasing serotonin, most of them by blocking the reuptake of serotonin. That's just a way of maximizing the concentration of serotonin at the synapse, the junction between nerve cells where communication occurs and where the action of serotonin takes place. So the selective serotonin reuptake inhibitors, the SSRIs, medications like Prozac and Zoloft, they're among the safest and still the most widely prescribed antidepressant and anti-anxiety anxiolytic medications available. And they're a real boon to millions of patients worldwide. Also, the SNRIs, not so much the first generation tricyclic antidepressants, those as well, but I'm thinking more of Effexor, venlafaxine, and Cymbalta duloxetine, the more modern SNRIs, as well as Vibrid and Trintellix, and just a lot of newer multimodal medications that also increase serotonin. They're highly effective, non-addictive medications, non-habit-forming medications that save lives, and they are very well tolerated. Unfortunately, among the most common of side effects induced by these medications are those that typically prove to be among the most recalcitrant. I'm talking about sexual dysfunction in the form of one, a relative inability to climax. That's a delayed orgasm or sometimes complete anorgasmia, the inability to climax. Or if you are able to finally achieve climax, it's just not as satisfying as normal. And or, number two, a decreased sexual arousal, decreased libido, which in some males manifests as erectile dysfunction. While there are other side effects that are caused by these medications, such as queasiness, headaches, and diarrhea, those resolve rapidly and for all intents and purposes completely with continued use. You can count on that. Sexual dysfunction is one of those pesky side effects that can persist for many months, or even indefinitely. For some patients at some doses, it gets better to a certain point, but it never goes away entirely, and you get actually little or no improvement. This is similar to weight gain and temperature dysregulation, hot flashes, and disruptions in the sleep-wake cycle, middle insomnia, and early morning awakening. You can check out my other videos for more information on those, but those also tend to be chronic side effects that don't go away entirely. Sexual dysfunction as a side effect is one of the leading reasons why people who are otherwise benefiting from treatment with these types of psychotropic medications seek to discontinue them. I would say it's the number one reason among a certain demographic, which is the vast majority of anywhere from young adults to senior citizens. For other people who recognize that they need treatment with psychotropic medications just to function, people with severe endogenous illness who are willing to make sacrifices, sexual dysfunction is something that they more or less, quote unquote, learn to live with. So this video is going to address how to avoid or at least minimize sexual dysfunction when treatment with these types of medications is deemed valuable and necessary. So if you elect to stay on these medications, here are some things that you can do to avoid sexual dysfunction. Well, the first would be don't take an SSRI, all right? So that's not really what I'm going to focus on in this talk, but if you require treatment with psychotropic medication, one obvious strategy is to avoid those antidepressants that are known to cause sexual dysfunction. The problem is that most of them cause it, at least the ones that increase serotonin, which if you need that kind of antidepressant, if you need to reduce anxiety or irritability or anger, then you need serotonin. You can't just take Wellbutrin. That's not going to help you. Strattera, that's not going to help you. It's not going to address the core of your symptoms. So how can you avoid it? How can you get around it? Mirtazapine is one medication that I'll talk about in a minute that increases serotonin not by reuptake inhibition, and it has no anorgasmia because it blocks another serotonin receptor subtype. So it has less sexual dysfunction across the board. You don't really see it with that medication as much, but it's also not as effective at reducing anxiety. So the really good ones, the really effective ones, tend to have reuptake inhibition as the mechanism of action, at least one mechanism of action for increasing serotonin, and those cause significant sexual dysfunction. So again, while it's true that Wellbutrin doesn't cause sexual side effects, in fact, Wellbutrin, by increasing dopamine as well, can actually be an antidote for the anhedonia, the decreased libido that you get from serotonergic medications. So you can actually add Wellbutrin to help with that, or even in a patient who isn't taking antidepressants, maybe a postmenopausal woman who's having trouble with her libido, you can add Wellbutrin as a non-stimulant alternative to increasing sexual drive because of that dopaminergic action. It is an aphrodisiac, but it doesn't act on the serotonin system, and so it doesn't help anxiety, and it can actually make anxiety worse, and it can especially make irritability worse. It can make anger worse, and so it's just not a substitute. You should never switch from Prozac to Wellbutrin. You can add Wellbutrin if you're having side effects, or if you're having other symptoms that Wellbutrin can help with that the serotonin is not addressing from the SSRI, but switching doesn't make any sense. I do see that sometimes when a patient complains of sexual dysfunction. That just doesn't make sense. They're not going to get the same relief from their symptoms. It's by increasing serotonin that we protect people from crying spells. That's another threshold that Wellbutrin isn't going to touch. You need a serotonergic medication to increase the threshold for crying spells so that you're not crying all the time, if that's one of your target symptoms. Decreasing irritability, blocking panic attacks. Wellbutrin is a good antidepressant for individuals who aren't particularly anxious or irritable, but it doesn't do anything for those other symptoms. So while avoiding manipulating serotonin levels is one certain way to avoid sexual dysfunction, there are relatively few available medications that work this way, and the ones that do are often not indicated. Number 2, wait for it to get better. This is obviously the easiest thing to do, and sometimes it even works. Almost all side effects do improve over time, most fairly rapidly and significantly, if not completely. Unfortunately, as previously stated, sexual dysfunction tends to persist, often indefinitely. It does get somewhat better for most people given enough time, depending on the dosage, if you're not just on a real significant dose. However, a conservative wait and see strategy is not always effective. It's not entirely unreasonable, especially for those patients who are suffering fairly serious mood problems for whom sexual health can wait. For those individuals who are severely depressed, sexual arousal actually often improves with treatment of their depression, and it's just not a priority at the beginning of treatment anyway. But the ability to climax is usually the complaint that you see among patients who are experiencing sexual dysfunction due to medications. The good news is that all sexual dysfunction side effects are reversible with discontinuation of the offending medication, no matter how severe they are and no matter how long they've been going on. Even after months or years of sexual dysfunction due to treatment with medication, a person will revert to their baseline upon discontinuation. Now, that may be a controversial statement for some people. There is a condition that is rare. It's not just uncommon, it's rare. I've never seen it, but it is a syndrome in which, and it does exist, it is a syndrome in which sexual dysfunction persists after a person discontinues using an SSRI or another serotonergic medication that caused sexual dysfunction. However, there really is no pathophysiology that explains it. It is extremely rare, and it's controversial in the sense that it's not clear. It is not established that it was the antidepressant that caused it. And so there could be other factors. It is a psychosomatic condition. It's always influenced by psychological factors, mental factors, stress, and especially when you see it after somebody who only took an SSRI for a few days or a few weeks, you have to look at that and say, it's probably not the antidepressant if it was just a few days. And yet there are people out there who will claim, no, it was the medication. Now, for those people who took a serotonergic medication for months or years, I think they have a stronger case. And I'm not saying definitively that there isn't something that taking the medication triggered, but it's unknown. It's really not known how to treat those patients. And I'm going to stick with saying that the vast majority of people, there's no permanent change that occurs. You're going to get back to your baseline. And if you don't, we need to look at other variables besides just the fact that you took the medication, especially if you're not taking the medication anymore. And we know for a fact that your physiology, just like everyone else's physiology, is going to upregulate those serotonin receptors that were downregulated all that time. You're going to return to the homeostatic conditions as far as serotonin, the serotonergic homeostatic conditions that were dictated by your genes, which haven't changed. These are facts. Taking a serotonin medication doesn't change your DNA. So I don't think that you need to worry about permanent changes. I really don't think that that's something we need to warn patients about, even though it is a thing, it is a syndrome, it's so rare, and it's so unproven, and I'm certainly not up on the latest research about that, so I don't want to make any blanket statements. But always confer with your prescribing physician before you make any adjustments to your psychotropic medication, especially discontinuing medication. Number 3, lowering the dosage. Most side effects are more or less dose dependent. There are some that are not, like weight gain, but what that means is that they are first noticeable when medication levels reach a certain threshold, and then they intensify with increasing doses beyond that. And sometimes, a lot of times they plateau. I mean, if you're vomiting, you can't really get any worse than that. I mean, nausea can, you can vomit and then the nausea can continue to increase and get even more intense, so that's possible. But at some point, you're just not going to get more nauseated than you are. You're maximally nauseated. But in general, the greater the dosage, the greater the potential for the side effect, and the more intense that side effect is likely to be when it occurs. One way to avoid vomiting is to begin at a low dosage, increase it gradually over time, take it with food to slow down the absorption. And if a person continues taking it regularly, that person will become more or less immune to the nauseating effect of the drug. I could say really 100% of people, given time. Again, there's always a subset of people who do not. And it's really, those people are in the minority. It's rare. Those people probably have something else going on underlying, where there are syndromes of idiopathic chronic nausea. They get nauseated at the drop of a hat, and they get very severe nausea. And even though you would expect that after months of taking 10 milligrams of Prozac with food, they should not have any nausea, they still report nausea. And it can't be explained physiologically. So again, you're probably not going to be one of those patients. If you are, there are things that we can do. You can even give those patients Zofran and strong prescription-only antiemetics, and they're still telling you that they're vomiting. And I just think there's something else going on with patients who are such extreme outliers that they defy mammalian physiology. But in psychiatry especially, you can see that. You can especially see that. Similarly, we can expect sexual dysfunction to get worse with escalating doses. The difference is that sexual dysfunction often becomes quote-unquote complete at fairly low doses. An individual can lose her sex drive altogether, or an individual becomes completely anorgasmic, sometimes with initiating doses, fairly low doses. So lowering the dosage isn't an option if it's the starting dose or the lowest dose, or if it's a subtherapeutic dose, if it's not the dose we need to take care of anxiety, for example. It usually requires higher doses. So the start low, go slow strategy that works so well with other side effects such as queasiness and diarrhea may not apply with sexual dysfunction. And even if you start low and you don't have it, and then you go slow, eventually when you reach that threshold and you get it, going very slowly doesn't further obviate it the way nausea and headaches and diarrhea are obviated by just going very slowly. You cannot experience diarrhea if you just take the lowest dose and you take it with food and you wait and wait and wait before you increase it. It's not that way with sexual dysfunction most of the time. Number 4, try a different SSRI. If you're on the lowest effective dose and you've waited long enough and your doctor doesn't feel that you can or should avoid an SSRI altogether, know that different SSRIs tend to cause varying levels of sexual dysfunction among different people. So if one medication is causing severe problems for you in this area, you might want to discuss switching to a different medication in the same class. Among SSRIs, Paxil is the most notorious. It's the most potent inhibitor of serotonin reuptake in vitro, which on a milligram per milligram basis translates into some of the most impressive and problematic sexual dysfunction clinically. It's also, in my experience, one of the most effective SSRIs, but in my experience, it is the worst one as far as sexual dysfunction. So I avoid prescribing it when sexual dysfunction is a key concern. On the other end of the spectrum, citalopram, and especially S-citalopram, Celexa and Lexapro, are among the least problematic in this area. They are the most selective serotonin reuptake inhibitors. They are the most selective of the selective serotonin reuptake inhibitors. I'm not saying there isn't sexual dysfunction, but it tends to be minimal, especially at the lower doses. Again, sexual dysfunction is dose dependent. So it's not to say that those medications don't generate those types of complaints as well. They certainly do. The choice of antidepressant is a complex one. There are many factors that need to be considered. I do another video on how to choose among the SSRIs. Please check it out. But you have to consider the target symptoms, you have to consider the person's personal history, what medications they may have tried in the past, and what worked and what didn't work, and what kind of a response they got. Maybe if they've taken a medication in this class and they had terrible sexual dysfunction, you can expect that you're going to see it again. Family history is often very important in terms of medication response, especially first-degree relatives. So a parent, a sibling, or a child, you might have an adult child that took the medication and had a certain response that you might also, you share 50% of your DNA. Sometimes we look at that. The potential for other side effects also has to be considered. So you have to consider all these factors, and at the end of the day, you should always confer with your treating physician in choosing the right medication trial that's right for you. I certainly can't make any one-size-fits-all recommendations, but know that not all of these medications are created equal when it comes to inducing sexual dysfunction. Number 5, timing. This is very important, and it's a point that few physicians make. So I think this is the pearl. If you take anything away from this talk, this is the most important point, I think, of this video. It is the pearl, because most practitioners, even psychiatrists, are not counseling their patients about this. And certainly primary care physicians are unlikely to do it. The SSRIs are taken once daily, sometimes in divided doses, but usually one time a day. And once you reach steady state, that means your serum blood levels are steady. They're suitable and they are not fluctuating widely, because you're on a certain dosage and you're taking it once a day, and the half-life is permissive. The half-life is about a day or longer. And so if you're taking the medication at intervals that are less than one half-life, then after 5 half-lives, you reach steady state. And when you've been taking the medication long enough for certain physiological changes to take place in the brain, you're getting the beneficial effects of the medication on your mood, and that lasts all day, as long as you don't stop taking the medication. So the half-life is about a day, so you need to take the medication every day. Like the effect on a person's mood, sexual dysfunction will also tend to occur at a more or less constant level while a person is taking the medication. However, with regard to difficulty achieving an orgasm, so I'm talking very specifically about anorgasmia, and again, that's by far the most common complaint among patients taking these medications. Well, I shouldn't say that. It is more common than the others, because both men and women experience it to a certain extent, and men, for example, rarely complain of low libido. They tend to complain of erectile dysfunction, and usually it's the only middle-aged gentlemen or older gentlemen who maybe are on other medications and have other health problems. So my number one complaint when it comes to sexual dysfunction is anorgasmia. And timing when you take the medication can actually make a huge difference in terms of anorgasmia. So although it may always be more challenging to achieve an orgasm while you're taking this SSRI, there are times when it will be virtually impossible. And one of those times is immediately after dosing, when the level of the medication in the bloodstream is essentially, it's peaking. So even though the fluctuations are at a minimum because you're at steady state, and you're dosing it regularly, there's still going to be some fluctuations. After you take it, you're going to have a little spike, especially if you're on an empty stomach and the dosage is significant, you absorb it rapidly. But if you take 200 milligrams of Zoloft, for example, and then an hour later you attempt to climax, you're going to experience monumental difficulty doing so. And you'll probably quit trying, quite frustrated. If on the other hand, you attempt to climax as far removed from the last time that you dosed, you'll have a significantly improved chance of succeeding. There's no guarantee that you will succeed. Of course, you might continue to be frustrated, but your chances will be much greater. And so what you're going to want to do is dose it as far away as possible. So 24 hours, if you can do it. If you're usually sexually active in the late evenings, let's say, then you should take the medication right before lights out, right before you go to sleep, right after you're sexually active. If it's in the early evenings, the same deal. Try to time it that way if you're having particular difficulty with anorgasmia, right after you are sexually active. Again, always check with your doctor before you adjust your dosing schedule and just do what works best for you. And you might have to experiment with a few things. So having to schedule times for sexual activity may not be convenient or even feasible for a lot of people. A lot of people are a little bit more spontaneous and they like that spontaneity. And some couples need that spontaneity. But at least knowing that there are zones of time during which you're more or less likely to be able to climax can save you a lot of frustration and also help you to be more patient while you wait the weeks or sometimes months that it can take for spontaneous improvement to occur regarding this bothersome side effect, if it's going to occur at all. I have to be honest though, if it's not better after about 6 weeks or so, you're probably looking at what you're going to be stuck with. Number 6, antidotes. There are various other prescription medications that can be added to your SSRI for the specific purpose of reversing sexual dysfunction. I've already discussed how Wellbutrin is one medication that can be added for this purpose. By increasing dopamine, it can be a good treatment for anhedonia, specifically decreased libido. Buspirone is another medication that can be very useful for reversing anorgasmia because it blocks a certain serotonin receptor subtype, and mirtazapine by the same token. This is a hit or miss strategy, though the addition of these adjunct medications can significantly improve sexual dysfunction in some individuals while making little or no difference at all for others. And it's also, I think, also a dose-dependent phenomenon. So you gotta make sure that you take enough of it. But if it's gonna help, it's gonna help right away. You don't have to wait 6 weeks. It's gonna make a difference within, I would say, within a week or 2, just as soon as you get to steady state, which for most of these medications is about 5 days. The downside, of course, is that it involves taking yet another medication with the cost and inconvenience and potentially other new side effects that taking the prescription medication entails. But when it works to reverse the dysfunction, most people feel that it's worth it. And you might also get an added boost to your mood as far as antidepressant efficacy, or in the case of mirtazapine, it might be a really nice non-habit forming sleep aid if you're having a little bit of trouble sleeping. You just have to watch weight gain. So there are always risks and benefits, there are always pros and cons, and everybody's case is different. So finally, a note on erectile dysfunction. Men who experience ED as a result of treatment with these types of antidepressants and anti-anxiety agents are almost always men who have either previously experienced ED or who are otherwise at risk for it. So we're not talking about young, healthy men that are on no other medications. We're talking about older, middle-aged gentlemen with histories of high blood pressure, high cholesterol, and or diabetes, for example. So because SSRIs can diminish the libido, the sex drive, lowered arousal can certainly contribute to some degree of ED. And then any medication that increases norepinephrine, which is the sympathetic arousal, the sympathetic nervous system, is also bad for the erection. Then there are certain serotonin receptor subtypes that if you stimulate them, you're going to cause erectile dysfunction. So there's a lot that can go on there pharmacodynamically. The fact is, though, that most men are not going to experience a complete loss of their sex drive. Even older gentlemen that are having ED and other forms of sexual dysfunction, that effect of not having a sex drive at all, that's more common in women, and of course, especially postmenopausal women. Even older men with established ED will rarely complain that SSRIs have completely deprived them of their interest in sex, or that as a result, their erectile dysfunction is noticeably worse. Rather, these men are likely to complain about the decreased ability or relative inability to climax. Of course, for those few individuals for whom ED does seem to be a consequence of treatment with an SSRI, any of the above strategies apply, but if there are no other medical contraindications, using medications approved for the treatment of ED is certainly worth considering. Thank you for listening, and comments are always welcome.